Time for another Puscast. This one covering August 1st through 15th, 2012. A warning. It's summertime and the living is easy, and I am doing this Puscast on the front porch. So there may be, despite the fact that I have a pretty good microphone, some extraneous noises. You may hear birds or the occasional car go by, and you'll certainly hear dogs barking because I live in a kennel. My neighbors love to let their dogs bark and don't give a rat's ass that no one wants to hear them. But this is not the Listen to Crislip complain about his neighbor's dog podcast. This is the Puscast covering the infectious disease literature. As always, I ask that you go on iTunes and write me a glowing review. And if you do, and you let me know, I can send you the world's greatest peach cobbler recipe. The peaches are out and the cobbler is delicious. Otherwise, this is brought to you by Pusware LLC, the publisher of the Infectious Disease Compendium, a persiflager's guide. You can find my growing multimedia empire at moremark.squarespace.com. The references are available online. And I'm sick of this intro, so let's get to the meat of what I think is going to be a relatively short Puscast because I couldn't find that much stuff this week. I don't know how many of you get asked questions for which there is no answer. It is not an uncommon cause of consultation for me. Hey, I got this rheumatoid. They have osteo. When can I give them TNF inhibitors? I don't know. But there is an interesting study that looked at the issue at the risk of patients on immune modulating agents who have RA. They found that the risk of serious infections doubled in the first year after starting tumor necrosis factor inhibitors, and that after the first year, curiously, that risk faded away. I don't know why the risk would fade away. Perhaps because those who got infections tended to drop out of using TNF so that you selected for a group that was able to tolerate the drug. The other interesting thing is that they found that patients who are on more than 8 milligrams a week of methotrexate were more likely to develop a significant infection. Evidently, this had not been reported before, but the amount of methotrexate was also important for determining who got infected. So next time I get a patient who has an infection that I've cured and RA, and I get asked, can I give TNF? I now have an answer. It will be, I don't know. Epidemiologic evaluations often yield results that you wouldn't expect just on the basis of your clinical practice. It's why the words "in my experience" are so stupid in medicine. This study looked at moxifloxacin and levofloxacin liver toxicities. It was a study out of Canada, and they went back and looked at all the patients who had received a variety of antibiotics. They had 1.5 million records that they looked at. And they found that patients on moxifloxacin were more likely to be admitted to the hospital with liver toxicity. This risk was double that of patients on clarithromycin. And also, levofloxacin had the same effect, although not quite as dramatic as moxifloxacin. Now, this wasn't a huge number of cases that had liver toxicity. It was 6 admissions per 100,000 exposures, but still about 2/3 of them died during that admission. Curiously, this was not seen with ciprofloxacin, although cipro has the other toxicities one worries about. I've always been a beta-lactam kind of guy, and I'm glad that I still am. You need to feel sorry for the house staff at Good Samaritan Hospital. They have no choice but to listen to my rants, where you have the advantage of fast forward or can just hit the off button. One of my ongoing diatribes is the fact that anyone who uses the terms strong, big gun, or powerful in reference to antibiotics is an idiot and knows nothing about the use of antibiotics. That being said, there is archetypal crappy antibiotics, and vancomycin leads the list. It's toxic, it has poor pharmacokinetics, and it is not very good at getting rid of staph. Compared to beta-lactams, for example, vancomycin always has about a 30% higher failure rate. Not good. But we are awash in MRSA, and we are using more vancomycin than ever before. Should we be using it prophylactically in surgery patients? Well, the answer to that is yes or no. The study out of Australia looked at vancomycin versus beta-lactams for prophylaxis and found while they did make somewhat of a dent in their MRSA infections, their MSSA infections went up. Further evidence of just how crappy vancomycin is. The risk of developing an infection across the board was 5.3% in patients on vancomycin versus 3.2% in patients who received a beta-lactam, and MSSA did lead the list as causative organisms. At our institution, we have implemented the New England Journal of Medicine article wherein patients are screened for staph, and if they have staph, are decolonized. With great prescience, I said that, well, if they're MRSA positive, and given what a crappy drug vancomycin is, let's prophylax everybody with vancomycin and cefazolin, although our pharmacists, for some strange reason, prefer cefazolin. I don't know why they like cefazolin so much when cefazolin's a better agent. It turns out that was a wonderful idea on my part, as it would be suggested from this article that if you have to give vancomycin because of a concern of MRSA, you should give a beta-lactam as well, so you actually have some good surgical prophylaxis. I like to think that I own the property on which my house sits, but the scrub jay, which I just watched hide some food, just gave me a stare down that makes me think he owns the property. Oh well. When should you get blood cultures? Well, we get them all the time. This was a study out of JAMA that looked at all these studies about the utility of blood cultures. And they found 35 studies with 4,500 bacteremias and 25,000 negative blood cultures. You can see that blood cultures don't have a great yield. Cellulitis, for example, only has a 2% yield for bacteremia, whereas septic shock, it occurs 69% of the time. They tried to determine in this test, when's it a good time to get blood cultures? Well, an elevated temperature alone does not predict bacteremia. So getting blood cultures for temperature greater than 101 in and of itself is not of great utility. Although one wonders about the ICU, where you don't know if a single fever is going to represent a bacteremia or not. They also found that isolated leukocytosis does not predict bacteremia. But the best bet for having a positive blood culture are the severity of the chills. A rigor usually means they're bacteremic, and the presence of SIRS. They also have a multivariable decision rule, but those are never used clinically. As an ID doc, of course, I'm of two minds on the issue, but certainly anybody with persisting fevers should get blood cultures if they're, say, in the ICU, but someone coming in with an isolated fever, maybe not so much. In the real world, blood cultures are probably like myocardial infarctions. When I was a resident, it was my impression that anybody who used the word chest and pain in a sentence got admitted for rule out. I was moving my chest of drawers looking for my Payne-Weber files. Rule out. I think that's driven in part by the fact that everybody knows of the case where the person came in with chest pain, was told not to worry about it, they went home and they died. Blood cultures are similar in that respect, in that you are unwilling, as a rule, as a practicing clinician, to miss a positive blood culture. So I don't know if studies like this are of great utility in managing practice. Even though the yield of blood cultures is always low, I think practice is always going to drive getting too many of them because no one wants to risk missing a bacteremia. A pair of the deaths that we had during the H1N1 pandemic at its worst were due to neurologic events. Their MR showed basically a bad encephalitis. But how often does that occur? It looked at the neurologic manifestations of H1N1 in California. They used those who had severe or fatal H1N1. So that was 2,000 cases. And they found that a whopping 20% had neurologic manifestations, which is pretty remarkable. Seizures was the most common with 44 patients, but 30 of the 2,000 had encephalitis, although in this series most patients did well and survived. And while both cases I took care of were middle-aged white females, the California series, it occurred mostly in pediatric cases and in Asian Pacific Islanders who more likely had neurologic manifestations of H1N1. But a 20% involvement of the brain is pretty impressive in severe influenza. A couple of years ago, there was I think it was CID article that showed that severe influenza ran in families. As I remember right, they looked at the family histories in Utah where they keep extensive family histories and suggested that people were more likely to die of influenza in certain families. It's of interest that a Chinese study recently demonstrated that if you had a polymorphism in your CD55 protein, you were more likely to have severe influenza. So now we have a little bit of molecular medicine to back up the epidemiologic suggestion that your chance of dying of influenza may be in part genetically determined. No, I'm not drunk. Epidemiology. See, I can say it. As William Shakespeare said, the answer lies not in the stars, but in ourselves. This afternoon, I'm going on our annual trek down to the Clackamas County Fair. My wife grew up on a farm, so we always go to the county and occasionally the state fair, and it's always fun. She'll also talk to the animals. It's quite entertaining to watch her talk to chickens and pigs. Maybe I won't let her talk to pigs this year because, as you're probably aware, there's a new variant of swine flu going across the country. There have been about 150 cases since July. It's an H3N2, and the common contact is with swine. So maybe this year we won't go to the swine barn, though it's always so cute to see the mother pig with all her piglets that they have there. Baby pigs look so good. Pig. First we had H1N1, which was a summer disease. Now we have H3N2 from swine, which is also a summer disease. I think the concept of flu season has been disappearing. So why do patients get hypersensitivity reaction to Bactrim, especially AIDS patients? Turns out there is, again, a genetic predisposition. Bactrim, specifically the sulfamethoxazole component, is metabolized and in the process forms two highly reactive and toxic agents that, when binding to tissue proteins, activates the HLA to have patients have a severe reaction to TMP-sulfa. This study looked at polymorphisms in the glutamate cysteine ligase catalytic subunit. Ooh, of course, I would have thought of that. And found that those who had certain polymorphisms were more likely to be associated with a hypersensitivity reaction to sulfamethoxazole. There are other drugs as well where there's a genetic predisposition for having a hypersensitivity reaction, the classic, of course, being abacavir. But it looks like, at least in some HIV patients who get a problem with TMP-sulfa, the reaction to the sulfamethoxazole is genetically programmed. There are 3 other HIV articles of note this month. One, which I think is very important for the world, is that having patients on HAART markedly decreases the chance of spread of tuberculosis. Being on antiretroviral therapy is a good way to prevent the epidemic of TB that is slowly but surely sweeping the world. As I'm sure you're aware, HIV patients frequently die of cardiovascular disease. It is the number 3 cause of death in patients with HIV. The risk for myocardial infarction, having plasma HIV levels greater than 50. The lower your CD4 nadir, the more likely you are to have an MI, and the higher CD4 8 T cell count were all independent risk factors for myocardial infarction. Also of interest, in a study that was published at the AIDS meetings, aspirin is beneficial in decreasing platelet hyperactivity in HIV patients. This gets back to my continually harping on the fact that infections are inflammatory. Inflammation leads to prothrombotic state, and that leads to vascular events. Certainly true in HIV patients. It's probably true in everybody. Resistance of gonorrhea is going apace. It's going nothing but up. Turns out Portland, where I live, is one of the places where resistance to oral cephalosporins has gone up dramatically from 0 to 6.5%. The other large increases have been seen in Honolulu, where resistance to cefixime has gone from 0 to 17%. Minneapolis, where it's gone from 0 to 7%. In San Diego, where it's gone from 0 to 6.4%. And across the country, especially in men who have sex with men, elevated MICs to cefixime have gone from 0.2% in 2006 to almost 4% in 2011. Because of this, you can no longer use cefixime in the treatment of uncomplicated gonorrhea. So the CDC currently recommends for uncomplicated urogenital, anorectal, and pharyngeal gonorrhea an IM dose of ceftriaxone, 250 milligrams, plus a single dose of azithromycin, 1 gram orally, or doxycycline, 100 milligrams orally, twice a day for 7 days. If you can't give ceftriaxone because it's not available, they recommend cefixime 400 plus a gram of azithro or doxy. And if they're allergic to ceftriaxone, they recommend 2 grams of azithro orally. But key thing, if you use an alternative therapy, there should be test of cure a week later. At the rate we're going, probably within your lifetime, we will no longer have therapy for gonorrhea. Most people know that strep bovis is associated with colorectal cancer of some sort. What most people don't know is strep bovis is now called Streptococcus gallolyticus subspecies Gallolyticus Streptococcus bovis type 1. So if your lab reports a Streptococcus gallolyticus bacteremia, they probably have a colorectal neoplasia. How likely? Well, they had 98 people who had a Streptococcus gallolyticus bacteremia who got scoped. 57 had adenomas and 12 had invasive carcinomas. So a grand total of 69 out of 98 cases had bowel cancer, and of those, only 4 of them had suspected bowel cancer. So that's a screening test that's up there with a guaiac in terms of looking for cancer. I have no doubts that in the near future they will change the name of Streptococcus gallolyticus to something else just to piss me off. Yes, the world does revolve around me, and that's why microbiologists change the name of organisms. So, I like gram stains, and I probably shouldn't. This study looked at the utility of gram stains in the diagnosis of ventilator-associated pneumonia. They found that a negative gram stain, i.e. no organism seen on the smear, was highly associated with the no VAP. However, a predominance of organisms seen on the gram stain correlated poorly with the organisms cultured as a cause for your ventilator-associated pneumonia. So that a negative gram stain helps you decide that maybe they don't have pneumonia after all, especially if you do other tests and everything comes out negative. But a positive gram stain can't be used to guide therapy because the culture data does not correlate well with the gram stain data in patients with ventilator-associated pneumonia. Although to this day, trying to get a good microbiologic diagnosis of VAP is still problematic, since everything you collect goes through the upper airway. There was an outbreak of gastroenteritis at a convention that initially was thought due to norovirus, but subsequent testing, it was discovered that everybody actually got Clostridium perfringens toxin as their cause of their gastroenteritis. And this study in CID pointed out it is probably a commonly unrecognized cause of outbreaks. I certainly never think of Clostridium perfringens, probably because I don't have testing available, but it is something to consider should you see an outbreak of the Hershey squirts, especially when you consider that C. perfringens probably accounts for about 10% of outbreaks of gastroenteritis. Macrolides such as clarithromycin have been shown to be beneficial in the treatment of patients with gram-negative infections, and for years you've heard me harp on the fact that it's probably due to non-antimicrobial effects, immunomodulation, and the like. Well, maybe not after all. God, I hate being wrong. But this study looked at Pseudomonas susceptibility to macrolides and ketolides and found that while Pseudomonas was resistant when you tested them in standard microbiologic lab systems, if you used growth media that are used to grow eukaryotic cells, it turns out that pseudomonads are actually quite susceptible to macrolides and ketolides. So that the old saw that if you use azithromycin, say, in a patient with cystic fibrosis, that the effects are due to immunomodulatory effects may not be true after all, and that it depends on what media you're testing your organism as to whether or not it's susceptible or not. There is still something to be said for the whole immunomodulatory effect of macrolides in infections, but maybe you are also getting some beneficial killing when you give them macrolides, or at least screwing with protein synthesis in organisms such as Pseudomonas, which is helping in those infections as well. This is one of these examples of why I love ID. So get this. They found a 17,000-year-old bison. It's an extinct bison. And they used gas chromatography on it, and they found evidence of tuberculosis in this 17,000-year-old skeleton of a bison. Now, interestingly, the oldest evidence of TB in human skeletons is a mere 9,000 years ago. So this would suggest that tuberculosis started as a zoonosis and then subsequently spread to human beings. Although the discussion does mention the potential presence of TB in a 500,000-year-old human skull, maybe not. But I just think it's cool beans that they found TB in a 17,000-year-old extinct bison skeleton. Just a nice report in CID demonstrating that the level of the beta-glucan correlates with outcomes in the treatment of Candida. Certainly the beta-D-glucan is a nice test for diagnosing invasive candidiasis, but they found that treatment success correlated with decline in the levels of the beta-glucan. And that's it. Told you to be a quickie this month. Only 22 minutes of fascinating infectious disease factoids. This ends the Puscast, a review of the infectious disease literature, covering August 1st through 15th, 2012. Don't forget moremark.squarespace.com, where you will find my growing multimedia empire of podcasts, blogs, books, and iPhone and Android apps. And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation. Bye.